I say all welcome here on this webinar, and it's a big honor for me to speak here for Dental XP to tell you a little bit about our concept here in Frankfurt University, and a lot of things already mentioned here. So we go to the first slide. First, for a concept, you should always consider the patient's demands, and a patient won't always look very nature-like after your restoration. And he always opt for a minimal invasive therapy intervention if there is a option for two different cases. And last not least, it should also is very time and cost efficient treatment. I think there's nothing new for you. And this leads to some prosthetic guidelines, and we called it here as a patient-oriented implantology. First we start, if you look here on our picture, no worry, there is no implant behind, this is pure nature. So what we see, the tools to replace is already a solved problem because we have good dental technicians, we have good all ceramic materials. So the main remaining challenge is the soft tissue, the shape, the contour, the color, and the maintenance. And so we have this guideline, and if you now look how we get the nature-like pink aesthetics back, we start in the implantology to create it because implantology are starting on a healed side, especially on the edentalist jaw, and then we move up to single tooth gap. And to get some knowledge and not to reinvent it everything new, we have to go in the back, in the past, how we can solve this problem without implants. And you know, the Merchant's profile was published more than 8 years ago in Journal of Dental Research, that this is working without implants with pontics, which are shaped like, some egg, some ovid pontic shaped, and we press it in the soft tissue. There are several methods for that. And you see, you get good papilla, you get a good contour of the facial aspect. And therefore we can say good aesthetic Merchant's profile, the pink aesthetic, doesn't need any implant. We can do it also with prosthetic bridges, and you see here again very nicely shaped soft tissue, and this is only a bridge, a 3-unit bridge, which is caused by an ovid shaped pontic. And if you remove this bridge like you see here, you see on this, please follow the green arrow, some red soft tissue, and in former times, I think, and a lot of others too, this will be inflamed or whatever. But we know since a long time this is not inflammation mostly, this is only a wound which is disrupting the soft tissue which is attached to the ceramic which are veneering. So, and this is of course a problem because they have to get a next healing. And if you look at this publication of Zitzmann, that the ovid pontic, this was a histological observation in humans, is not associated with a clinical signs of inflammation. And here a very nice SEM, or surface electronic microscopy, and you see some fibers connecting the kind of healing abutment, and if you remove the abutment, you will destroy, of course. So now about this knowledge, we go to come back how we can create in a healed site a good emergence profile with implants, and you will know the same way, of course. Here again we have a cantilever bridge, and if you see the red line, this is the border and which is defining the emergence profile. And if you have no implant, you have a small diameter implant, a wide diameter implant, it doesn't change this borderline. That means the diameter of an implant platform or abutment is not influencing really the kind of emergence profile. So we don't need an implant and we don't care about the implant diameter. In other words, even with small diameters, you can create very nice, good emergence profiles. Once again, here the two-dimensional graphics. If we have a tooth between a pontic between two crowns, we call it a bridge, but there's no implant behind, and you see the emergence profile. If you have a needle implant, of course it will immediately broke, but the emergence profile you see again with the blue arrows not changing. And if you have a platform switched implant system, like here the Ankylos, and you have a small diameter with 3.5 millimeter, you can get very nice aesthetics in big molar crowns too, or central incisors. And of course it works too with wide diameter, and we have a lot of experience that wide diameter works in the first time, but on the later we have some recession on the buccal aspect sometimes because the bone is surrounding the implant is very thin because it's the wide diameter. So, and now we come to the next objective for the patient's demands. Minimal invasive. And minimally invasive means not only minimal invasive in the surgery approach, it's also coming up to the prosthetic working steps. And the prosthetic working step, you know about the term better than here in Europe. The one abutment, one time term means if you remove now the abutment, not the bridge, you have the same problem. You disrupt the soft tissue from the abutment after the soft tissue is attached or is healed on. And this gives a wound, and you see it's bloody. And this is not minimal invasive. So we don't want to do it if it's possible. And the same is with the healing abutment. If you have a healing abutment, we don't want to remove it. So the innovative workflow we have to think about is, if it's ever possible, work without an healing abutment, without an impression abutment, without a temporary abutment. And I think, this is not very nicely for the companies because they want to sell it. And therefore, this workflow is not very happy in some of the manuals. The same is with one crown, one time. If you place, and if you have the chance to place immediately the final crown, not the temporary crown, the soft tissue doesn't know. The soft tissue doesn't know this is a temporary crown or final crown. However, if the maturation is ready of the soft tissue, you don't have to remove this final crown and disrupt again and destroy the connection. And this is minimal invasive, and this helps us that the soft tissue is not rejecting again. Next point, so if ever possible, work without a temporary crown. And the next time in Frankfurt, we start 16 years ago to stop the probing. Now we have a very nice paper from Schwarz 2010. He make a dog model study and he make probing on one side on the test group, and on the other group he has no probing. And you see the frequently clinical probing increased the mean pocket depth. So we create here wounds which will get resorption of bone. And last but not least, we have to talk about the time and cost-efficient treatment in a single tooth restoration, and especially on aesthetics. And the past for us is perhaps for you the present. Don't be worried. It's not wrong. We do it a long time and it works 100%. And I show you very quickly the workflow we can do with a single crown in aesthetic zone. We have a lot of prosthetic working step after we are assembling a round healing abutment. And you are familiar with this working step. And these working steps are combined in 1 or 2 or 3 appointments. So the patient has to drive to your dental office 2, 3, 4 times. It depends. And I show you one case. We start always wrong. The soft tissue is shaped with a round healing abutment, and this is definitely wrong, because it creates a wrong merchant's profile. So what we do is we remove the healing abutment, we make an impression, and after the impression we make a master cast, and we tell the dental lab, please make us a temporary crown to reshape the wrong shaped soft tissue. And then we get back this temporary crown on a temporary abutment, and you see you put in and out abutments, and after there were some adapting and reshaping of the soft tissue, we are happy. Yeah, and you get a better emergence profile, but now you have the next impression. And you see, if you compare the two impressions, that we are a little bit better with the emergence profile. But you have always to assemble and remove abutments. And then you make the second master cast, and then you decide for the final crown. You place a final abutment, you place a final crown, and you get a good result, no doubt. However, I think you agree with me, this is an inefficient protocol. To shape first wrong and then right. So it's not anymore working with a single tooth restoration. And it doesn't get achievement in the objective minimal invasive because you remove always the abutments in and out, and it's not time and cost efficient. You get only a good final result, and this is shown in papers, in congresses, and in your own patients. And this is the reason that it still survive the inefficient protocol. If you go now to, I think, more efficient protocol, you see we have eliminated more or less every working step, prosthetic working step, of course, in a submerged healing mode. And it doesn't matter which time, which loading protocol you use, delayed or immediate loading protocol, you end up always in assembling in the final abutment and inserting in the final crown. And now you think, oh, it's very new. No, it's very old. We do it since 1969, and it was introduced by Nobel. They called it at that time simpler in practice. What that means is immediate indexing after implant placement. Here a case from this time. So this case is 15 years old. So at that time we have a healed side. We placed MK2 Nobel with a smooth surface at that time. And then the carrier was used for impression, and this impression was done by an index, which is done by a self-curing resin. And this will substitute the impression taking. And you see the carrier together with the index was given to the dental lab. And the dental lab will place the carrier together with the index in the planing mastercast. You see later videos. And it was fixed with pattern resin, and then you have a mastercast. And on this mastercast, we make the final crown, and then after 3 or 6 months, we make a re-entry. We place the final crown with the final abutment, and then we only look on the healing. And so we have only 2 sessions. Placement of the implant, and after 6 months, re-entry with placement of the final abutment and the final crown. So it's nothing new, but it's more or less a little bit forgotten. And sometimes you cannot place a full crown because you make an immediate loading protocol. Yeah, you place a half crown, but with a half crown, the soft tissue was shaped the same way, anatomically. So we call this anatomically shaped healing abutment. And with this anatomically shaped healing abutment, we work in the normal way. So we don't place a round healing abutment. Because it makes a lot of work later. We place a customized anatomic healing abutment. Means we tell the dental lab, please produce ahead some abutment which is more or less shaped like a root. And this root-shaped healing abutment will help us that we get a better starting point for going on with prosthetic steps. Of course, we can also use prefabricated anatomic healing abutment. Unfortunately, the companies are not motivated enough, I tell them 6-7 years ago, to produce these healing abutments because it makes so easy on the prosthetic side of the implant therapy. You see big abutments, anatomically shaped, but the soft tissue doesn't know if it's a half crown or a full crown. So soft tissue starts immediately from the first second after placement to shape in the right way. And you see here some pictures of a prospective clinical trial, with a round healing abutment and the anatomically shaped healing abutment, which is much bigger. And after you remove it, you see that on this side, the soft tissue, is much more in the vertical because the papilla are starting to come here. And here we have flat situations. And after we come back, then we have a better situation. The same is if you have this working flow again. I show you here some case. So if you have a non-submerged healing mode, you place this anatomical healing abutment, which is now not available on the market. You have to do it now by yourself. You remove this anatomical healing abutment, and because you have now the ready to go, you place the final abutment, and then you place the final crown, and you can take this also in 2 sessions in placement of an implant and restoring the implant in 2 appointments. So this is not a big issue. Okay, so with a minimal invasive therapeutic intervention with a 1 abutment 1 time, 1 crown 1 time, and elimination of probing, we are on a good side not to disturb the soft tissue healing and maturation and not be on risk that there is any retraction. Here once again, You place the final abutment, you place the final crown, even the soft tissue is not ready now. You see here it's not healed here. But after 3 or 6 months, the soft tissue is shaping very well. But now you have the big advantage in the one crown, one time concept. You don't have to remove it again and destroy the more or less good connection. And you have here the 1-year recall and the 2-year recall. It's stable. It's very stable because we are working very minimal invasive, avoiding a lot of assembling and removing of abutments, and even avoiding removal of a temporary abutment, a temporary crown, and temporary crowns for shaping. So with this protocol, I think we have achieved every 3 objectives. We are ending up in a very good nature-like restoration, looks good, aesthetics. We have minimal invasive therapeutic intervention, and we are very efficient in this protocol. Of course, we have to talk about the problems. If you have a master cast producing the final crown, you have on this master cast, after indexing, no information of any soft tissue in the vertical. So we have to create the crown which has no information about where is the crown margin. To come out of this problem, we have only one solution. We have to make deep crown margins, and a lot of people, especially prosthodontics, are not so happy with this solution. And I can understand, but it doesn't matter, because the soft tissue doesn't know which kind of material is abutment and which kind of material is veneering of the glass ceramic. You will see that. So we go down with the crown margin very deep, because then the border is deep and the soft tissue, even we don't know where is the vertical end, the vertical level on the after maturation, we don't care about that. I show you in this case, yeah. You see the soft tissue here is very deep with the crown margin. So there is 2 lines, yeah, the crown margin and the level of the soft tissue. We go 3-4 millimeter down. And now you have this crown and the very long crown. You do nothing wrong if you have the crown margin a little bit on the top, but what is absolutely clear is that this kind of the part of this of the crown is for free, because the crown from here to here at the same price we from here to here. So this will help you to get a very good soft tissue color. Why? Because if you see, the light is coming and the light is transported, the light is transported very well through the glass ceramic and will illuminate the soft tissue from the back. So the light is not disrupted by, or is not interrupted by any crown margin, which is a little bit bad for aesthetics. So we get very nice aesthetic results here. You place the crown, you see this is a picture after cementation, and this is a picture 3 years later. You don't see any soft tissue discoloring on this picture. And the same is with the next one, yeah. We have a deep crown margin, and if we have a deep crown margin, you cannot see any discoloring of the soft tissue, even if you have a titanium abutment. You have uninterrupted. But now you will think, oh Paul, you make deep crown margins and you spoke about cementation. It's impossible to remove, like on this case, any cement on this deep crown margin. I'm so happy that I have now a CAD-CAM customized abutment, which the crown margin is more or less on the top, and I can remove the cement very easily. Yeah, you're right. But then you cannot use this protocol. So what is the solution if we have a deep crown margin and nobody of us, me too, can remove the excess from the deep crown margin? We have to introduce a new cementation technique and of course the appropriate cement. The appropriate cement is very easy. We use more than 19 years, not a resin-based, you hear right, not a resin-based, because a resin-based is very bad to remove and you see nothing because it's only a small layer. And even you have an all ceramic abutment and the all ceramic crown, you see a lot of swollen soft tissue, which is a little bit red. It's more or less a micro-inflammation because the soft tissue is attaching not the good ceramic material, no, it's attaching the resin of the cement. So to come out of this problem, we recommend you strictly for this deep crown margin to use only mechanically retained cementation materials. So in Frankfurt we use zinc phosphate cement or temp bond, because small cement are more or less washed out on a polished surface if there's only small excess. But more important is more or less the technique to prevent any excess, and this is very easy. What we do is we make a cementation first outside, and I will show you this video first. So yeah, it's working very well. So we have a cementation die. It's a replica of the abutment, and the nurse will fill the crown outside of the mouth with cement, but we cemented it first outside. Yeah, you see the cement here was temp bond, was bringed in, and then outside of the mouth we have best possibilities to remove more or less 100% of this cement, and then we get sure that we can place even crown with a deep crown margin, which are also aesthetically very, very nice. We see on this case later. So this was the situation for cementation. Do it externally first. Now we come to the next part of the lecture. We have saying, okay, we can create it after a healed site. The other way is, if we have already a tooth and we have to extract it, unfortunately, the better way is not to lose it first and then you create it again, what we do a long time, because after extraction we wait 6 months and then we have, of course, a healed site. So the main idea was that after extraction we can keep here the contour, the shape and the color originally. So it's much easier to keep something than in case to create it after you have a healed site and you have to hope that it get it back all the best way. And this is, of course, more and more common used, and we have to look about the knowledge for socket healing, because if you extract a teeth and you place immediately an implant, you have to know something about the socket healing, that you get sure that everything is working well. And one of the best papers I can do is Gadaropoli, and he finds that the first thing what a socket have to do is to close it with soft tissue first, but even the first bone coming is the socket to close. So the bone makes a bridge to close the socket, and this is clear because this is the only point that we can survive, because 10,000 years there was no antibiotics and there were no dentists, but we have traumatic tooth loss, so the person has to survive also if we have a traumatic tooth loss. And so it's a nature healing program that the socket was sealed biologically after you have extracted tooth or lost the tooth without any further treatment. Now in implantology, surgeons want to have the same dimension, so we make a lot of things we call socket preservation. But with the socket preservation, we only keep, or we believe to keep, the dimension of the areolar ridge. But you see on this picture very well that after closing it with a free general graft, we lose, of course, on time the contour of the soft tissue, so that we end up again in a healed site. Doesn't work. And even Fickel shows us very nicely that socket preservation also causes some resorption of the buccal bone. So it's not a really preservation of all things, especially the buccal bone we resorbed here. So we cannot keep everything with a socket preservation if the name is saying that. Another approach published by Arayujo is placing immediately the implant in the socket. But you see on this implant, on the histological finding, they have a very severe bone loss on the buccal aspect, especially on the premolar side. And yeah, this is, we have a lot of reasons to discuss. I go only very shortly in 2 or 3, because crestal bone loss, we know you can have crestal bone loss after a bad surgery. You can overheat by drilling. You can have too much pressure, augmentation, and also unknown reasons. Or you can have problems in the soft tissue with bad oral hygiene, or the cement excess we already discussed, or we have some overloads or not loading. This is also creating crestal bone loss. You can download here on this website also other videos which are showing you other brands of implant system, how they work, how there is a micro movement after cycling loading. The solution in our point is the implant abutment joint, which has to be a cone, because if you have a cone, the seal is between the abutment and the implants secured, and therefore there is no pumping effect anymore. And this we can also prove in our investigation, that if you look here on the video again, this is the ankylos with the cone, Morse taper connection between abutment and implant. And if you now look to the video, you see that if I load it, there is no gap formation between abutment and implant. So this was the situation for cementation. Do it externally first. Now we come to the next part of the lecture. We have saying, okay, we can create it after a healed site. The other way is, if we have already a tooth and we have to extract it, unfortunately, the better way is not to lose it first and then you create it again, what we do a long time, because after extraction we wait 6 months and then we have, of course, a healed site. So the main idea was that after extraction we can keep here the contour, the shape and the color originally. So it's much easier to keep something than in case to create it after you have a healed site and you have to hope that it get it back all the best way. And this is, of course, more and more common used, and we have to look about the knowledge for socket healing, because if you extract a teeth and you place immediately an implant, you have to know something about the socket healing, that you get sure that everything is working well. And one of the best papers I can do is Kadaropoli, and he finds that the first thing what a socket have to do is to close it with soft tissue first, but even the first bone coming is the socket to close. So the bone makes a bridge to close the socket, and this is clear because this is the only point that we can survive, because 10,000 years there was no antibiotics and there were no dentists, but we have traumatic tooth loss, so the person has to survive also if we have a traumatic tooth loss. And so it's a nature healing program that the socket was sealed biologically after you have extracted tooth or lost the tooth without any further treatment. Now in implantology, surgeons want to have the same dimension, so we make a lot of things we call socket preservation. But with the socket preservation, we only keep, or we believe to keep, the dimension of the alveolar ridge. But you see on this picture very well that after closing it with a free general graft, we lose, of course, on time the contour of the soft tissue, so that we end up again in a healed site. Doesn't work. And even Frickel shows us very nicely that socket preservation also caused some resorption of the buccal bone. So it's not a really preservation of all things, especially the buccal bone we resorbed here. So we cannot keep everything with a socket preservation if the name is saying that. Another approach published by Arayusho is placing immediately the implant in the socket. But you see on this implant, on the histological finding, they have a very severe bone loss on the buccal aspect, especially on the premolar side. And this is, we have a lot of reasons to discuss. I go only very shortly in 2 or 3, because crestal bone loss, we know you can have crestal bone loss after a bad surgery. You can overheat by drilling. You can have too much pressure, augmentation, and also unknown reasons. Or you can have problems in the soft tissue with bad oral hygiene, or the cement excess we already discussed. Or we have some overloads or not loading. This is also creating crestal bone loss. However, you have always mentioning that every reason is working like a chain. So if one reason occurs, the bone reason is more or less inevitable. So you don't need 2 or 3 reasons together that you have a crestal bone loss. One reason is enough. So if you find one reason, this can explain sometimes in cases a bone loss. And one of these reasons we find out is the micro movement between abutment and implant. And I show you here on the next video that if you load an abutment, you see the gap formation between abutment and implant. So this is also later on you can download on our university website. And this is one of the reasons we have to deal with. So the point is, if we now bring some water onto this gap, we will see that this causes also some fluid which is pumped in and pumped out. And we will see here on an animation how it works. This is the animation which hypothesis we have. The opening and the closing of the abutment interface will cause fluid release, and the fluid is very, very aggressive to the bone. Can I have the next video, please? This was only animation. And now in the next video you see an X-ray beam, and if I start the video we can prove that this water coming in and out, so that we have some pumping effect between abutment and implant. This is done by Mr. Ziprich and me, this investigation. And this we think is some of the reason that we can lose bone. You can download here on this website also other videos which are showing you other brands of implant system, how they work, how there is a micro movement after cycling loading. The solution in our point is the implant abutment joint, which has to be a cone, because if you have a cone, the seal is between the abutment and the implants secured, and therefore there is no pumping effect anymore. And this we can also prove in our investigation, that if you look here on the video again, this is the ankylos with the cone, Morse taper connection between abutment and implant. And if you now look to the video, you see that if I load it, there is no gap formation between abutment and implant. And if I can have the next video, of course we have done the same here with the water which was marked for the X-ray beam, and we can now not see any exchange of the water in and out in this in vitro setup. So this is a very strong proof of principle that there is no exchange of the internal cavities, which the bad fluid, which has the pH very low, there's a very aggressive fluid, to the soft tissue which is surrounding here on the platform. So this is one reason that we think that the bone can be kept. On the other way, if you have a leakage, the bone can be resorbed, and this leakage is more or less the reason that a lot of implants lose the bone surrounding the implant abutment interface. Okay, so if you now see the results, it's very easy. You see here a publication of Wang, the bone on the ankylos here, which is sealed, can be kept. This is a dog model study, very nicely done. And we here on the clinician side, we see also on a very long term run, so 6 to 8, 10 years, that a lot of implants don't lose any bone here. So most of the implants can keep the crestal bone for a very long time. So this is a very good feature. We call it also the tissue care connection, that the tissue will be kept here. And you see also some X-ray. We can see in a two-dimensional way, and more with the cone beam CT, we see also on the buckle aspect that it can kept until the platform. So a next point is that we can also lose bone here on the study from Cochrane. Even on implants which have no implant abutment joint. This is the tissue level implant from Straumann, and they lose 2.5 millimeters. So we have to find another reason that bone loss can occur, because here we cannot say this is the pumping effect, because it's more or less a one-piece implant system. And we have here some hypotheses that coming from engineer, if an implant is loaded from horizontal like you see here, we have on this side a little bit pressure on the bone. And this is also a reason that the bone can be a little bit resorbed. And if you now have an implant system which has a step on the level, on the bone level, so between bone and air or a soft tissue, this will give you a very nice feature because the load is the same and the strain and the pressure is also the same, but the distribution of the strain is changing. So most of the strain is coming to the edge, because we know on ceramics, if you have an edge, there is a strain concentration. So if 80% on the strain is here on the edge, only 20% strain or pressure is remaining between implant and bone connection. And this will help that the crestal bone during the healing phase is not overloaded and therefore not on risk that you get lost. And this is also the reason that if you look on the next video, I make an animation that mostly the bone is stopping on the first thread. You know about the first thread phenomenon, yeah, that the bone is stopping at the first thread, or the resorption to the first thread, but the bone is never going to school, and he never let counting that he stop in the first thread, but the first thread is the first place that the strain is a little bit reduced. So if we go down more, the strain is again coming up. So mostly the first thread is the end point of the bone resorption in normal implants. Then this is one of the reasons of the strain distribution. So this was also proved on a very good publication from Maeda from Japan. He make a investigation on finite element analysis, and you see that if you have platform switching, you can move the strain into the platform on the edge. And this is shown here very well on this paper. So it's not only theoretical, you can have also a proof on papers. And now you can imagine that a platform switched implant system is nothing else as a simulation of the first thread. And this is shown here, that the first thread and the platform switching is more or less the same for the bone. And this is a reason that if you have a platform switched implant, you have to place it subcrestally. Because if you have placed implant system, you place it supracrestally or crestally. Sometimes, the platform is ending up supracrestally, and then this effect cannot work. Here you see another presentation or animation. So if you place a platform switched implant system subcrestally, mostly the bone ends up here, like here you on the animation you can see. Why we place it subcrestally and not crestally like other companies like Noble with Noble Active or Straumann with bone level? Because after healing you lose mostly a half millimeter bone on the crestal level, and then you end up supracrestally, and this is bad. Okay, going on this knowledge about platform switching, that we know platform switching is only working if you have a sealing between abutment and implant, otherwise platform switching is not working. So you need a cone seal and you need a subcrestal placement of the implant. And this is helping you to keep the crestal bone. Why I tell you all this story? Because in the aesthetic zone you get brilliancy. In the aesthetic you need the buccal bone and of course also the initial height of the buccal bone, and this will help you if you use a platform switched implant system which is sealed. So, and now the next point is about the socket healing, that if you have a traumatic loss of a tooth and you don't place an implant but you place back the tooth again, we spoke about a re-implantation of a tooth. And we have a lot of literature, unfortunately it is about 30 years old, mostly done on monkey studies also. We know that within 1 or 2 days the soft tissue is healed perfect. You don't see that the tooth is already extracted or traumatic loss. So this is the immediate seal of the fresh extraction socket by the biological seal. And so we call the prosthetic socket preservation nothing else as a simulation of an intentional reimplantation of the biological crown without the root. So we don't place back the whole tooth with the root, we only place back the crown to seal. So we want only to seal, because this is also the program of the body to seal a socket immediately. And this is we call it prosthetic socket preservation. I show you on one case. Unfortunately, this patient has a longitudinal deep root fracture. We cannot save this teeth, so we have to extract, even it looks very good. And of course, we want to keep the soft tissue in the original shape and contour. Unfortunately, mostly patients cannot place immediately implant because they have to rethink about it, or you have no implant on the stock, or you have to talk about the financing and so on. In this case, we want to keep it, of course. What we do is we make an index again. We have to extract the tooth, and now we go back with the tooth without root. We separated the root, and we have to go minimum 3 millimeter into the extraction socket to be sure that the seal between the soft tissue and this part of the root of the tooth is coming again. If you go only 1 millimeter in the socket, you will have a collapsing of the socket the same way. So if you go now back, we make a re-implantation of the tooth. It's also described by others. And then the soft tissue will seal immediately, and the next day you get a very nice outcome, and the tooth is only anchored on the neighboring tooth like a Maryland bridge. But then you can keep the soft tissue originally for some days, for some weeks with this way. So you don't need an implant. So what we learn is, if you seal the socket with a biological crown, the soft tissue doesn't care which kind of anchoring this biological crown has. You can anchor this biological crown by a neighboring tooth with a pontic, or you can anchor this with their own crown, with their own root, and we call it a reimplantated teeth. Or later on, you see, you can anchor this biological crown, of course, also with an implant. Yeah. So you see here the day before the extraction and after the extraction 1 day. It's a very nice result, and it's very predictable. So we have, for that knowledge about immediate placement and restoration, the following point. First, we want not to have too much assembling and in and out of abutments. Secondly, if we have to extract the tooth, which is hopeless or more or less hopeless, we have to do it without any flap surgery. Because we know if you have a flap surgery, you lose soft tissue and bone too, especially on the buccal bed. So we have to take it minimal invasive. The next point is you have to seal the socket immediately. Best way with the original biological crown, or with a temporary crown, or with a half crown. And then we need the one abutment one time to be minimal invasive also to the soft tissue. And of course, we have to use the appropriate implant for this therapy concept to get brilliant aesthetics. The implant should have a very nice primary stability, so it needs a special thread design. This is also in the Ankylos, is also in the Noble Active, very fine. And yeah, you need a platform switched implant system which is sealed, that you get a very high probability that you can keep not only the mesial and distal bone on the platform level, you should also get the buccal aspect, the buccal bone on the platform level. Okay, with this knowledge, I show you now some case, step by step, like a cookbook, the last 20 minutes of this lecture. So, typical case, patient comes to this lost, we don't find him. We have to extract the teeth and we want to immediate placement and restore this case. What we do? First, we tell the dental lab, please make us a temporary crown for relining later ahead. So this was made ahead by CEREC. You can also make it by resin. You can press it, whatever. But only the outer contour of this temporary crown is important. The inner surface has no fit anymore, and also not because this was later on relined, you see on the video. So, and the next step is, of course, after extraction of the tooth, we place the implant. So, if you now place the platform switched implant, what happens? We have to find the deepest point of the bone. Mostly it's a buccal bone, so mostly we have to place this implant very deep, because we have to go to the deepest point. But this doesn't matter anything because the implant abutment connection is sealed, so not a bad fluid comes out and will have very bad side effects on the bone. The bone can be kept even you place the implant deep because the buccal bone is more or less 2 or 3 millimeters away. This is a big point. So coming back to the presentation, after you place the implant, so we have to make the index key. Yeah, this index key is made by by resin, you see. And this index key is made on the carrier of the implant, so you don't need a impression abutment. Yeah, so this is not good for the companies, but you place any kind of implant in, and then you make here with a self-curring resin like ProTemp this index key. It's a very easy job. It's a 2-minute job, mostly delegated to the nurse. And now we see on next video clip how we work. This is the planning cast. You see the teeth is not already extracted in this time where we make the impression taking. So now the dental technician has to put in a hole. So you have also to extract the teeth like you and have to grind in a big hole in the planning cast. Next video, please. And then the dental technician or also the nurse, will connect the carrier together with a transfer key with the analog of the implant, you see. Yeah. Next video, please. And then this analog implant together with the index key was placed in the originally planning cast. So the hole was filled in with some resin, and then you can put in the analog abutment. Okay, next video, please. And after you place the implant here with the index key, you can make the abutment selection outside, also extra early. And this is a very interesting thing because you now find the best abutment. You don't do any squeezing of the implant. Next, please. Next video. Then we shape a little bit the abutment outside, so we make a hand customizing. Yeah, next video, please. And after we have shaped it, and this is always bringing down the crown margin very deep, I already tell you, because you see on this that there's no information where the soft tissue is, because we have no information of the soft tissue. We can only bring down the crown margin of the abutment very deep. We make a relining of our temporary crown, which was more or less made before. And this relining was done with composite, and please do it outside. If you do it in the patient's mouth, you have no control about the resin coming into the socket. And this is, of course, not minimal invasive. You can do it outside, and you have a very good chance to be in a very good position if you do it outside. Yeah, it's very important that we have the one abutment, one time concept, that the dental technician doesn't forget that if we now place the abutment finally in the patient's mouth, the master cut is worthless because he has no final abutment anymore. So, and therefore we have the need, we have the must that we make a replica of this master cast by taking an impression, or to make another replica by scanning or by some other silicone procedures. This is a very important point, but it's a lab point. And after you have finally mounted this abutment, we have now the absolutely perfect thing that this abutment is never removed again, and the soft tissue can attach from the first second on without any disruption later on. So this we call the one abutment, one time concept. We already know that the abutment has now a very deep crown margin because we never know where the soft tissue margin will end, so we place it a little bit deeper, and therefore we need a special cementation technique. And now we see the first the video. What we do is we make a replica of the abutment, of the customized abutment. And for this we take the crown and fill in some self-curing resin. So this is from 3M Esper, this is a Pro Temp. It's a resin for temporary restoration, and we fix it with a dowel pin or with the old burr, and after the curing time of 2 minutes, you see, you have more or less a replica of your cementation abutment. And if you have this replica, you have a very good feature for removing every excess of cement of this kind of cement excess. So we go now on. This is now the cementation process. You see here the cementation piston, we also tell it. And with this video we will show you that the rule for cementation with a deep crown margin is very easy. You have to cement the crown first externally to the replication of the abutment we already produced. And if you see, this is, we do externally first. Yeah, this is a replica of the abutment, and the abutment is already mounted, you know, so it's fixed and mounted. And now the nurse will fill in the cementation material. It's mostly a temporary material, so we use here Temp Bond from the company Care. And of course, they will always apply a little bit too much cement, and then we press it externally out, and now we have the perfect case to remove the excess of the cement. And you see, it's a very easy procedure. It should be done within 1 minute. You have time, 2 minutes. So, and then we place the crown onto the final abutment, and we are now sure that there is no cement excess which is disturbing the healing process or will cause any inflammation on the soft tissue. It is a very safe method. We use it for a very long time, and we have very good experience. Of course, there is a small a little bit less cement between the crown and the cementation die, but remember, there is not a tooth with dentin with a risk of caries or with a barotrauma. This is only an abutment, and if you have a screwed crown, you have no cement between the gap of abutment and crown, so don't worry if you have a little bit less amount of cement between the crown and abutment. So after this cementation method, you see here, this is the day 0 after placement of the crown. And we are now happy that there is no cement leaving between crown and soft tissue. And if you look after the 2 days recall, we see that there is a very, very good healing without any sign of inflammation, because no cement is disturbing the healing. And of course, we have sealed the socket, what was the main target of this procedure, to have a perfect seal to simulate the re-implantation of a tooth. And of course, it's very important for every protocol for immediate placement in a socket and the immediate restoration with a crown that there is no occlusion between the temporary crown and the antagonists, and you don't have to splint to the neighboring teeth, because if you have a splinting to the neighboring teeth, the movement of the periodontal ligament during the action between the occlusion will be transported to the implant, and this is a movement which will destroy the healing in process, and you have a high risk of failure. So once again, no occlusion and no splinting to neighboring teeth. A splinting is only allowed if you have a implant-borne crown, because the implant-borne crown is not moving with a periodontal ligament. Okay, so once again we start with this initial situation of a traumatic fracture of the canine, on the left side on the upper jaw. And if you now look here after 1 week, we get a very healthy looking result, and we have only to wait now for 3 months or 4 months for a perfect osseointegration of the implant. But if the sealing is perfect, this is not changing anymore. And here you have the picture after 4 months. Yeah, so the oral hygiene is not the perfect one, but these are old patients. But you see there's no inflammation, and the implant is also very strong and is very tight, so you can now start with the final restoration. This protocol was also published in the first description here on this paper for my working group, and this is the rationale for aesthetic tissue preservation of a fresh extraction socket by an implant treatment concept simulating a tooth replantation, and of course without any flap surgery, and with the main target to seal the socket with the own tooth, or with a temporary crown for the first second on. Now we have a protocol for the immediate placement and restoration of an implant with a central incisor. Here we have done for more than some 3 years ago. So we have here the situation that you have on the number 8 a fracture line, and then number 9 we have the fracture line very deep, and you can see it in the X-ray. So if the patient comes at midnight, you have first to fix a problem, because at midnight nobody is there, you cannot place an implant, or if the patient cannot decide immediately, so put back the old crown if it's possible, to seal the socket with the own crown, and you fix it only to the neighboring teeth, and this is working for 1 or 2 days perfectly. Because if you don't do this procedure and the patient is coming the next day, this situation is not there. You have a collapse of the soft tissue. But if you remove now this opening of the socket, you have a very good situation. And now we do the same what we see the case before. We have to extract the root very atraumatic, non-invasive, without flaps, without burr, and there are here a good chance for a lot of devices existing on the market, which we can pull out the root like the cork of a wine bottle. You see here this device. This is a Switzerland company. It's called Benex system. It's a very nice system, but you have also 5 other systems in the market, which is helping you by very easy procedure to pull out the root very atraumatically without any cutting and burrs and loss of a lot of bone and soft tissue by flap surgery. Okay, after you remove this root, we place implants here, in this case the ankylos, and mostly we place it a little bit more palatally. And what you can now recognize very easily, after the immediate placement of any implant, you have a big jumping distance. That means a big distance between implant surface and the socket wall, especially in the coronal or crestal part. And we have now a lot of literature, which is very good papers, that say that if the jumping distance is more than 2 millimeter, so you have to make some membranes or some augmentation procedures to prevent a very fast growing in of the soft tissue in this big gap. And if you now place a round healing abutment on this case, you have to do a membrane or something else, because there is a high risk. But now if you place the final crown or a temporary crown to seal this socket, you will have the point that the sealing has the same task like a membrane. So the cervical part of the crown have now the same task and like there's a membrane. And this is the point, that the soft tissue is attaching to the crown and is not growing into this jumping distance. So it's now up to you to make the decision to place some autologous bone material or some bone substitute materials like BioOS into the scap, which is recommended in a lot of papers, but it's not absolutely necessary in our in our treatment concept. And the next step is to manufacture the index key you already see in the video, to have a perfect three-dimensional transfer from the implant platform into the planing master cast. Yeah, you see this is a main procedure. You see it in the video before. And on this master cast now we can make again the abutment selection. We can make again the handmade customizing of the final abutment at the same day. And mostly we only bring down a little bit the crown margin, especially on the buckle side. And after this customizing, we make a relining on this master cast. We already see in the video with a composite material. Here we have the happy situation that the original crown was not lost, so we remove the dentinum of the original crown and we make a relining on the master cast. And so what we have now here, you see on the left the final abutment, which was customized by hand, a little bit deeper crown margin. This abutment will be never removed again. And on the right side of the picture you see the relined original crown, and on the crown margin there is only composite, so it's a little bit longer now, but the surface is the original crown surface. You see also the crack of the trauma. And now after we go back to the patient with the transfer key, we have now only the need for 50 Newton centimeter for fixing the abutment finally. This is a big advantage in this implant system, because in other systems you need 35 Newton centimeter for a final abutment assembling, and especially in a socket you never have the absolutely sureness that you get always 35 Newton centimeters. Sometimes you get only 25 or 30, and then it's not possible to go on with the immediate restoration. Here we have only the need of 15 Newton centimeter torque, and it's easy to get this kind of primary stability in the socket. And now we have finally mounted the abutment. We close the screw hole with some resin or whatever, and you see already the jumping distance is not filled. We can fill it, but the clue of the thing is to seal now the entrance of the extraction socket, and this is done by the relined original crown. In this case, you see we place the relined original crown, and of course this relined original crown, it has a opaque color, so it's a little bit more bright than the neighboring teeth, original neighboring teeth, but this is because the animal is dried, so you have the same behavior of the natural teeth if you have a rubber dam after 1 or 2 hour endodontic treatment. But don't care about it, the real color will come back. So in this case we can promise the patient following. The next day, 24 hours later, we have the original color again, and because the soft tissue doesn't know is there this tooth anchored by the original root, then we called it a reimplantated tooth. If this crown anchored by the neighboring teeth, then we called it a Maryland bridge and a Pontic. Or if this crown, the implant-born crown, or anchored by an implant, the surrounding soft tissue, the soft tissue margin doesn't know about that. So the entrance was always the same. It was a sealing process to this, and we know about a lot of papers in the reimplantation of a tooth that 24 hours later you cannot see clinicianally in the clinic that there is an extraction of a tooth and the reimplantation of a tooth. So the next slide is showing you the case 24 hours later, and you see it's a very fast coming back of everything. You keep everything and you lose nothing, and this is the main target of this protocol. And you see also the original tooth, which was reliant on this abutment, was a little bit shortened to come out of occlusion. Yeah, and therefore we have a need to replace this temporary crown to a final crown, of course. Otherwise, perhaps you can use it also as a final crown. So after you remove 4 months later this temporary crown again, we are now very glad to say that there's no need to remove the abutment anymore, because on the replica of the Masterclass, a dental technician can make the final crown, the final orthoceramic crown, and therefore we have not destroyed the attachment again, which have the risk that we lose some vertical level of the of the mid-facial soft tissue on the buccal side. And so we have here the final crown, and you see the recall after 1 year. We have a very stable situation. There's no recession because it's an atraumatic treatment concept, especially in a thin biotype. You get here a very predictable situation. And yeah, we have only some patients because we started this, and mostly we can keep the teeth by endodontic treatment or by a very good periodontal therapy concept if they have a periodontal disease. But in case we have to extract the teeth for endodontic reasons or for fractures of the root, we can very good keep the mid-facial soft tissue in the same kind of level that we are starting. However, you see also, because we don't place any augmentation material in the gap between the implant and the buccal bone, we have a small depression here. And if you don't want to have it, you have to place some augmentation material in this gap. However, this is not a big aesthetic disadvantage. So yeah, you have to decide case by case. So it's not a must to put it in. You can put in. However, if you use a platform switched implant system and you place it a little bit subcrestally, mostly subcrestally on the buccal bone, you see that the bone can be kept mesially and distally, and we assume also buccally, but it's not allowed in Germany to make a cone beam CT, only to look after 1 year if there is a bone recession or not. So it's not allowed. Okay, so this is a 2-year recall. You see we have stable situation, and we assume that this is also working more and more in a very stable situation. Okay, so we start with these objectives, yeah, the contorization of the patient's demand, and I think this is a very nature-like restoration, and we have now soon the 3-year results, and we have no change about the soft tissue looking and also the crown, I can promise you. And it's of course a minimal invasive therapeutic intervention, and the protocol gives you a very time and cost efficient treatment option. And we use, of course, this protocol in these cases, and we recommend you, especially in a socket placement in the upper jaw, to place a platform switched implant system which is sealed and have a good thread design. And here you see the day 0. Yeah, we use here in this case the Noble Active, but the soft tissue doesn't know about that. So we can promise the patient after some days you will not see that this tooth is already extracted. You see here the placement of the Noble Active, which has a very aggressive thread design. However, you have also to mounted the abutment with a 35 Newton centimeter torque. And in the lower jaw, sometimes we cannot use this implant because the thread design is too aggressive and gets too much torque to this. And this is a recall after 1 week, and I think you see now more and more that it's a very predictable treatment concept, the same predictability like you extract the tooth and you get the same day the reimplantation of the tooth, and then you get a very good aesthetic outcome. The only risk is a resorption of the root after some years, but this is not possible with the implant placement, of course. So we get again the 3 objectives. And here another case which is okay, a little bit exception, but this is also a little bit outlook that we have some cases which are not idle. And here we have 2 lateral incisor, you see, and they are very loosened, so we have no chance to get it more tight. And if you look at the X-ray, you will recognize that the bone is, with the exception of the lateral incisor, it's a good condition, but here we have only the last 2 millimeters of the apex of the root surrounded by bone. And this is the reason that the tooth are very loosened. And the next point is that there is no buccal bone, of course, about 5-6 millimeters to the soft tissue margin. There is no buccal bone. If you now have the decision-making process, which kind of therapy you can do with this kind of patient, we decided that we extract the tooth, because forced orthodontic extrusion is not possible in this case, because the tooth is already too loosened, so we cannot develop the bone in the vertical aspect. And the gaps are too small to make a bigger vertical augmentation with other techniques, you know, about the ring technique, the teak bone graft technique, and so on. And therefore, we decide the same protocol you see before. We place the implants, and because we have to place it subcrestally, yeah, you see the carrier of the implant is really disappearing. We use here the ankylus system, because we have to measure that the platform of this implant system is a little bit subcrestal on the buccal bone, and the buccal bone is about 9 millimeters below the soft tissue margin. So the carrier is here nearly disappearing. And of course you will get a very, very long crown, and of course also very long abutments. In this very exceptional case, it's also not possible to make in a very easy way index, because if you make here an index, you have to put some self-curing resin onto the carrier, and then you will touch the entrance of the socket a lot, and this will be a trauma. So we decide that we place the long abutments. You see here the placement of the implants, and you see also the level, the vertical level of the platform, and it's very deep if you compare to the neighboring central incisor. So we make an impression. This was an impression of the abutment level. It's exceptional way here. And after you have the impression, the dental technician take this mastercast without any information of a ready soft tissue, of course, to make the crowns. And you now see the initial situation again. And we say that the patient, okay, we are happy if we can keep the soft tissue at the same level, because we have a little bit bad feeling at that time. It's now more than 3 years ago. That because if we have no buccal bone, we think, okay, there can be some recession. But nature told us another story, because we don't get a recession, we get a creeping down of soft tissue. And sorry, I cannot explain about that, and perhaps it's only one case and one case is no case. But what I want to tell you is, if you have a very nice attachment to a crown, you can have a very long attachment. And if it's atraumatic and you don't destroy this attachment, even a very long attachment can work for a long time without any inflammation. So yeah, the rule no buccal bone, no implant is a little bit relative. I think we need, of course, a buccal bone for placement of an implant. But if you are able to place the implant very deep to get a surrounding, a 330 degrees surrounding of bone, and you are able that you can place a long crown like here, because you have a very strong implant abutment connection, you don't have to have afraid of the long cantilever with a long crown, because the strong implant abutment connection can withstand this long cantilever. And the next is, even you have here absolutely a deep crown margin, you cannot control any remove of cement excess. So, but if you use our method for cementation, that you cement first axially, remove the excess of cement, and then you plate the crown, you never have the fear of a cement excess. So you see again, if you go back, there is no inflammation by cementation, which is not perfect working. So this I show you only to convince you about the potential if you make an atraumatic placement of implant and an atraumatic restoration without any cement excess. And we get again achieving these three targets we want to have: nature-like restoration, minimal invasive, and time and cost-efficient treatment. If you go now to the literature, to the recent literature, very good papers, no doubt. Here some of 2011 from Reyes and co-authors. You see very similar protocols: extracting a teeth, placing an implant. What is the difference? You will immediately recognize the difference between the therapy concept I lectured you today and to this paper is they use flaps for placement of implants first. Next, they use also 2 or 3 abutments to come to the final restoration. So they have the abutment changing. So they violate our target 1 abutment 1 time. And this is for us to discuss. This is, I think, the reason that they have 7% of the cases not working very well in case of aesthetics, and 7% in our eyes are too much. So it's not so predictable, because if you have more than 1 millimeter recession on the soft tissue in the vertical space, the crown gets more than 1 millimeter longer, and if the crown is 1 millimeter longer, it looks ugly. So even Reyes say a flapless surgery induced less midfacial recession than a flap surgery, and this is also a very good outcome of this paper. And so if you make not a flapless surgery, if you don't use the 1 abutment 1 time concept, you don't get a nature-like restoration, and it's not minimal invasive. It's perhaps time and cost efficient, but it's not worth to do it. A very nice study is coming up 2009 from Canulo, and he used the same protocol I show you. He extracted tooth, he placed the implant, he restored the implant with a provisional crown without occlusion. But he used in the control group a non-platform switched implant system, and in the test group a platform switched implant system, which is also sealed. And he want to see the influence of the platform switching versus non-platform switching in the outcome of the mid-facial vertical level. And you see on his x-rays in this paper that this platform switched implant also can keep mesially and distally the bone. And therefore we can assume also on the buccal side the bone can be kept at the same original level. And so we are not surprised by the results of this paper, that the test group with the platform switched implant shows no soft tissue loss in the vertical aspect. But the control group, which are using non-platform switched implant system, shows here a recession about 0.88 millimeter. And this is of course worse to use always a platform switched implant system which is sealed instead of a non-platform switched implant system in this special indication. Now let us summarize to get a nature-like red aesthetic. In my opinion, it's better to keep the soft tissue in the perfect shape immediately after extraction than to make a healing process of 6 weeks or 6 months and to have the risk for re-establishing everything again. It's possible, but it's a long way and it's not so predictable in our eyes. So this is an opportunity, and it's minimal invasive, it's time saving, it's effective, and it's a nature-like final result. Let us summarize the whole concept again. And we want to reduce it to the max. As I have learned in the United States, that simply the best and reduce to the max is do it easy and simple. And doing easy and simple is mostly accompanied to making minimal invasive. So first, you have to you give antibiotics for extraction, of course. Then you make a minimal invasive tooth extraction, is a flapless one with sometimes special devices if you have to remove a root. And don't touch the facial aspect after you extract the root or the tooth. So don't make a curettage on the buccal plate, because this curettage procedure will cause much more traumatic problems than if you don't touch it. Then choose an implant with a sealed conical connection and a progressive thread design. In other words, join a platform switched implant system with a conical connection. And place this implant platform a little bit subcrestally, which means place it subcrestally to the buccal bone plate, because the buccal bone is mostly the deepest one or the most apical one. And then mount the final abutment with deep crown margin only once. So this is a one abutment, one time concept. Fabricate the temporary crown on the master casts. Avoid any internal relining. And then seal the socket with a lined extracted tooth or with a temporary crown. It depends. And one point is very important. Use my cementation method. It's very easy. First, cement it externally on a replica die. Then remove the excess externally, and then the cement it internally. You see it on the video, and you can repeat it again. And then let it heal. That's it. So it's a very easy protocol, and I hope you will be convinced to do it tomorrow again by yourself. However, we have one disadvantage of this concept, and the disadvantage is, you cannot use it. Very rare. I say before, we have very rare cases during the year, because most of the cases we want to do everything to keep the teeth by endodontic treatment, by apectomy, by periodontal therapy concepts, and so on. So patients coming mostly too late, and they come with a hopeless teeth, and the hopeless teeth are in a very heavily inflamed socket, and this socket is then of course looking like this. This is the initial situation. This case is recently done. You see it on the date. You have a fistula, you have pus, the tooth is loosened a lot. And now we have to consider what can we do if we have this extraction of this tooth. And if you now look at the video, and we do the extraction. So look here. So it's a very short video. You see there's a it's not surrounded by bone, and after you extract this tooth, I think you will agree absolutely with me, there is no chance to get a healing with a therapy concept. So, and after we extract this tooth, we have only one chance for implant placement. We have to let it heal minimum 6 weeks, sometimes 6 months. And after the healing, you have a lot of loss of soft tissue and bone, especially in the vertical aspect. And though mostly we have to tell the patients after this, we have to make an augmentation. And after the augmentation, once again, you see here healing 6 months or 6 weeks, it depends. And then we have a re-entry, we make an augmentation, then the implant placement, and then the restoration. This is a very safe protocol. It works very well and is very well described, and a lot of papers existing about that. If you start with a very heavily inflamed socket, which coming pus and everything. However, if I have 10 patients with this hopeless teeth, I can only convince 1 or mostly 2 to do this protocol, because it's taking 1.5 years sometimes, and it's a lot of surgery, a lot of costs, and the patients don't like that. So we have to think about can we place an implant or can we not place an implant in this heavily inflamed socket? And yeah, this is the point that if we do this old protocol, we cannot be minimal invasive and not time and cost efficient, but we get a good result back, but it's costly. We also know if you place here a membrane or an augmentation after the extraction, it will end up in a disaster because it's not working with this inflamed socket. We have no chance. But if you look at the healing of a socket, you can assume that the placement of an implant of titanium, yeah, is not inhibiting and not avoiding the healing process or is influencing the healing process. This is an assumption. I cannot tell you if it's true or wrong, but we start with a pilot study. So, and this pilot study is done by a student of a master course here in the University of Frankfurt. We have a master course, a 2-year program. And yeah, this is the master thesis of him. So we look on the very heavily inflamed sockets and we place immediately an implant. And you see it on this case. We will also start soon a randomized controlled clinical trial, or RCT. And we don't recommend you to do it now. This should only be an outlook, because if it's working very predictable, this will be a revolution, because you can do it a lot of more to place immediately implant in the socket, because then we have more and more indications, because the patients mostly come in a situation which is too late, as a heavily inflamed socket. So now we have this situation again, and the next video is showing you that we place this implant really in this heavily inflamed socket. And of course, also in this video, we have to place the implant with the platform very deep, more or less the same depths like you see on the case with the lateral incisor. Yeah, don't worry if the bone is starting 5-6 millimeter below the gingiva or the soft tissue margin. You can place these implants very deep, because even you end up in a very long crown, yeah, doesn't matter, because you have a stable implant abutment connection. So, and then we close for the 2 hours this hole, and of course then we make the same protocol outside of the mouth on the mastercast. You already see the same protocol, and then we come back with a customized abutment, and you see one problem we have not solved yet until now. We have a heavily bleeding in a heavily inflamed socket, so the cementation is not easy, so we have not the perfect protocol now. And yeah, then we place and we cemented the crown the same way we do it. You see it already. And yeah, so this is the day 0. Of course, no occlusion, no splinting like the same day, the same before. And yeah, this is day 0, and you see the swelling on the buccal speck. However, the swelling is going away. In the next 4 days, he come to the recall, and you see the swelling and the inflammation is in a very good situation. So it's not really absolutely visible that there is a heavily inflamed socket again. This is a 4 days result. And yeah, after 1 month, it's really invisible that this was a heavily inflamed socket, and the implant is already starting to also integrate, and we wait 2 months more, and we will change this crown to the final crown. But once again, it's a pilot study. We have no data. It's an outlook, and I be very sure if we improve everything a little bit and the working steps, and we have data with a randomized control trial, we can recommend you also to use in the daily practice. But this will be a great future for this protocol if we can do it also in an inflamed socket. Of course, you have a recession here. if you don't want to have it, if you want to have a perfect result, you have to do the augmentation with after 6 months and so on. So some disadvantages you have to include in this topic too, of course. So I will thank you for your kindly attention, and we'll be happy if you now have a lot of questions, and we will discuss this with David Garber, and I hope we can see us yeah, next time in some meetings in the United States or wherever. And yeah, I say goodbye. Thank you very much.